right, y'all. And when you just log on, let me know who you are, where you're from. Also, let me know where you're from, because there's a lot of people that come on here that are looking for help, and they actually contact you. People I've seen, people saying, I want to come to you in your clinic. So you can help them that way. So I got a patient right now that has, he has hip arthritis, and he has SI joint dysfunction. So I originally diagnosed him with SI joint dysfunction, but he's 60-something years old, has a very labor-intensive job, and he has this pain here and here. Okay? Now, that could be hip OA, it could be SI joint, or it could be nerve, right? Not usually nerve, but it could be a nerve up there, right? And so the question is what are we dealing with? What is that? Or it could be a strained muscle, right? But what are we dealing with? What is that, right? So always. So what I always say in diagnostics is rule out what you can rule out, okay? So rule out what you can rule out. And what you can rule out is SI joint dysfunction, okay? Now, I don't have x-ray vision, but I can rule out SI joint dysfunction and do a test for hip OA. So in order for me to do what I'm about to do, first you have to realign the upslip. Remember, SI joint dysfunction caused by upslip and or outflare. Read my paper, pull it back down, and then you gap it open, and that's how you know when these symptoms go away, if it was SI joint versus, any other condition, sciatica or knee pain or ankle pain or something like that, okay? You immediately know when you gap and hold it open, okay? Let's see here. So, all right, let's see here. I'm going to have Inette come back here, bring this down. I don't know if you can see that. All right. And your back for me, please. All right, so to hip arthritis, the way that I diagnose it is I take them at a 90-90, and I internally rotate and I look at their eyes, and they're gonna jump if they got pain with this, in here. They'll jump. They'll be like, oh man, that hurts, So that's how I diagnose it. Just go like that and internally rotate it, and you're locking out the joint. Okay. So this person had pain with that, had pain in the thigh right here, and he's like, so we're trying to deduce what is what. Is it SI referred pain, or is it hip arthritis referred pain that can refer all into here as well, right? So what I did is I realigned the upslip, right? So I pulled on the leg first, and I realigned the upslip, okay? Make sure there was a negative prone press up test, and then I went like this, and I pushed her right ASIS medially, performing a gapping in the back. And when I did, immediately, when I held it there, I said, is it still there? I said, is that still there in your quad? And he said, no. So that told me that was coming from not his arthritis. He does have arthritis, but the referred pain was actually coming from SI joint. Thank you. So that is how to do a differential SI versus hip OA. It's real quick. You rule out what you can rule out. Don't make it all fancy. You don't need, so a lot of times you don't even need, all kinds of tests. Just you rule out the mechanical things, and then you get to structural issues, So if you can rule out mechanical things, then it's like, all right, well, there's something wrong here, If the person, if the person has, if I couldn't get that to go away, then I would have said, yeah, no, this is pretty significant arthritis in the hip that's causing referred pain. Now, what I do with that person is actually a Mulligan technique, self-Mulligan technique. I can't show it, it's not mine, but where they kind of use a inner tube, and pull that thing away, take Mulligan's courses. Anyways, that's that. If you have any questions, let me know. Other than that, peace, y'all.